want to start by thanking Clean Harbors for allowing us to use such a phenomenal training room. It's just a great venue for this and for all kinds of things. I want to thank Chief Ted Ross, who's Ted Snowball Chief. Thanks for lining this up for us, Ted. We appreciate it. I want to thank Hingham Media, who's going to be providing the video, and we'll also be we call it Facebook Live. Yeah, we're doing this Facebook Live, so if you want to leave, you can watch it in your car or something. Okay. So I want to start. Sheriff McDonald wanted to be here, but unfortunately he actually has jury duty and he didn't get out in time, so he's not here. But we do have DA Tim Cruz, who's been a phenomenal supporter, and obviously his task force, his county task force is where this was all born out of, the county model. So we have to have Tim here, so Tim wants to say a few words.
I just want to thank everybody for all the work that you're all doing. I know that it's everywhere right now. Last night I was in Hingham for Hingham Cares, and I was at Wakeman, and you see all the different groups and the coalitions with this real challenge. And when I talk to other district attorneys across the country, I'm on the National District Attorneys Association Board Opiate Working Group, and I talk about what we have here, from outreach to Plymouth County Hope to the task force that we have, and they just really, quite honestly, can't imagine getting, if they had 27 chiefs like we do, getting them in the room, never mind getting them to agree to something. So I appreciate the chiefs really coming together and making sure that we can put ourselves in a position where we can continue to collaborate and communicate and make sure that we can get the information, put together best practices. So I thank you all for what you do every day. I appreciate the fact that you're here today, and I'm hopeful that we can continue on down this path, and in a few years or so, or whatever the time frame may be, we'll look back at this and remember this is really the beginning of something good. And I want to thank Chief Oteri and Chief Allen for their leadership on these various programs. So thank you, and all have a good day.
Thanks, Tim. So at this point, we want to jump right into the training. Chief Allen's going to come up. He's going to tell you a little bit about what the next couple of hours is going to entail and introduce our speakers.
Great. So I have the pleasure of introducing Dr. Sarah Wakeman. Dr. Wakeman is at Mass General Hospital. She's the medical director of the Substance Use Disorder Initiative. For those of you that don't know, she's also the director for the RISE Massachusetts. Is the first mass hospital that in the ER is now implementing medically assisted treatment in the ER. In addition to that, she's an assistant professor at Harvard University and the program director for the Addiction Medicine Fellowship. We're honored. I mean, I've known of Dr. Wakeman for some time now, and when we talk about all these different options that are out there, I refer to her as the expert in this area that we're really pleased to have. So with that, I want to turn it over to Dr. Wakeman.
Thank you. Thanks so much for having me and for being here today. Thankfully, we missed the snow. I think we had to get rescheduled once already. So as you heard, I'm an internal medicine doctor and also board specialized in addiction medicine. So I take care of medical patients in community health center and also in the hospital, and then provide specialty addiction care. And I've had the privilege of being a part of Mass General Hospital's work to really redesign how we think about caring for people with addiction and how we begin to implement all the evidence that we know works for addiction into the medical system. And so I'll talk a little bit about that today. So I have no disclosures. So my hope in the hour that we have together is that you'll leave here understanding opioid use disorder as a chronic but very treatable medical illness, and that you'll be able to describe what effective treatment for opioid use disorder looks like. And I'll give you an example of that by talking through what we've done at Mass General to really begin to redesign our system of care for people in the midst of this crisis. So why are you here today? Why are all these wonderful and important initiatives going on? Well, more Americans will now die from drug overdose than from the peak number of HIV deaths during the HIV/AIDS epidemic, peak number of car accident deaths, and peak number of firearm deaths. So actually, overdose is the leading cause of death for all Americans under age 50, and more than 500,000 Americans have died since this crisis began. And when we think about what people are dying from, you hear people talk about the opioid crisis, and of course, the leading cause of death right now is opioids. And when we think about opioids, there's lots of different kinds of opioids, and there's been a lot of focus on prescription painkillers as one type. But as you can see, actually, in more recent years, the thing that is really killing people, that's driving the death toll, is ongoing use of heroin and illicit fentanyl, and we'll talk more about that. So what about prescribing? There's lots of focus on changing doctors' habits around prescribing, more responsible prescribing, and why is that so important? When we think about the onset of the current crisis, it was strongly correlated with changes in prescribing practices. So beginning in the late 1990s, early 2000s, doctors began changing how they prescribed opioid painkillers, and there's been a lot written about why that happened. You've probably heard about pharmaceutical companies' role in that. And the impact of that was that there was a lot more of prescription painkillers out there in the community. So we often hear sort of the narrative of a person who gets prescribed a medication then develops addiction, and that can happen, although that's actually the minority of cases. But more commonly, there was greater access to prescription painkillers in the community so that people, young people in particular, began experimenting with non-medical prescription opioid use, which can lead to prescription opioid use disorder and then transition into heroin use and other types of addiction. And so we see this correlation, which is the strong focus on prescribing. But what started the epidemic and what's sustaining the epidemic are not the same things. So actually, deaths from prescription opioids began decreasing in 2012. And as I'm sure you're all aware, what people are dying from right now is heroin and increasingly illicit fentanyl. And so when we think about strategies to address the current crisis of opioid-related death, of course, prescribing practice changes are important from a long-term prevention standpoint. But in terms of immediately stopping the death toll, the most important piece is getting people who have the disease of addiction treatment so that they can stay alive and get well. And this is just to highlight the dramatic change in fentanyl. So really, we say heroin, but for the most part, it's all fentanyl now, and I'm sure you guys are well aware of that. I can't really remember the last heroin-positive tox screen I saw. It's probably been at least 6 or 9 months. It's essentially exclusively fentanyl. And so as we've seen shifts in prescribing of opioids, we've begun to already see shifts in people's use of opioids. And so this is a study that came out last year that asked people who were being admitted to treatment, so addiction treatment, what was the opioid they used first that led to their opioid use disorder. And you can see in 2005, by and large, it was oxycodone and hydrocodone, so prescription painkillers as the number one. And yet already by 2015, there's been a shift. So actually, a third of people reported that heroin was the first opioid they used that caused a problem for them. So I think that really gets at the complexities of this crisis and why focusing just on supply, so just simply making it harder to access prescription opioids, is not enough to address this crisis. Because when people have a chronic illness, the disease of addiction, if all we do is make prescription opioids harder to find, we shift them into the illicit drug market and actually increase the likelihood that that person is going to experience an overdose and be at risk of death. So we talk a lot about death, and obviously death is the worst possible outcome and what we want to prevent. But for every person that dies from an overdose, many more survive, and many of those can experience really life-altering consequences, either from the overdose or from other consequences of their untreated addiction. And so as we've seen rising rates of overdose death across the country, we've also seen rising rates of hospitalization and emergency room visits related to opioid use. So sitting in a general hospital where I practice, our consult service is filled with young people who are dealing with really terrible consequences of untreated addiction: heart valve infections, bone and joint infections, strokes from non-fatal overdoses. So these consequences that can really lead to lifelong morbidity, and we often don't think about that when we're thinking about the many consequences of untreated addiction. But the other piece about this rising rate of hospitalization and ED visits is it really highlights an opportunity for engagement. So every one of those visits is an opportunity and a connection with the healthcare system, a moment when we can be offering treatment and initiating life-saving care. In addition, when we think about ICU admissions, so sort of the sickest of the sick who make it into the hospital, there's been a 34% increase in ICU admissions involving opioid overdoses between 2009 and 2015. And although if people make it to the hospital, so if they get Narcan in the field, hopefully, and are brought to the hospital and survive to get to the ED, most people will survive to leave the hospital. Only 10% actually die in the hospital. But after that, in just 31 months, another 25% of that group dies. And this is a young population. These are people in their 30s and 40s. So we're saving their lives in the short term, but if we don't treat the underlying opioid use disorder and they go back to the same circumstances that made them sick in the first place, their likelihood of relapse and ultimate death continues to be very high. So how can we begin to think about addressing this? Well, as a doctor and as a scientist, I think science is one of our most important allies when we think about how to address the current crisis of opioid-related death. And this was a great article by the head of NIDA, our National Institute on Drug Use, and the NIH, about addressing the opioid crisis and what science can tell us when we think about strategies. And they really highlight that when we think about any public health crisis or any epidemic in medicine, it's been science that has allowed us to get our arms around the crisis and save lives. And so I think starting there is an important piece. But before we get to sort of the research and the studies, equally important to science, I think, is narrative and the stories of people who've experienced this illness, who are living with this illness, who love people with this illness, I think often are a very powerful lens through which to understand what it's like to have an opioid use disorder. This is an old quote actually from the 1950s from William Burroughs' pseudo-memoir about his own experience with heroin addiction. And he really wrestles with that same question that I think we still struggle with, the sort of why does this happen to some people and not other people? And in fact, it's sort of amazing we don't all develop addiction because 90% of us expose ourselves to highly addictive drugs or alcohol during the course of our life, and yet most of us will never develop a substance use disorder. But 15% of Americans at some point in their life will meet criteria for addiction, and those folks have sort of the combination of genetic risk and environmental exposure that puts them at risk of developing addiction. And so as Burroughs describes, he tried drugs out of curiosity, like sort of the 90% of people who do, and he kind of drifted along using until one day he woke up sick and realized that something was different. And I think his point is that, no one chooses to develop addiction. So no little kid says, when I grow up, I want to have opioid addiction and I want to suffer from overdoses and get incarcerated and lose my home and my family. That's not a fate that anyone would choose for themselves. And so when we think about this complex notion of choice when it comes to addiction, absolutely people choose the first time they experiment with a substance. But again, nearly all of us make that willful choice. And yet for the minority of individuals who are at risk of having a substance use disorder, once that illness develops, they're not making a choice any longer to continue to have that disease and to be sick. And so what we know about opioid use disorder in particular is that we see this rapid change in the progression of the illness. So early on, people use drugs to feel good. That sounds sort of simple, but we often don't talk about the fact that using drugs have many positive outcomes, otherwise people wouldn't do it in the first place. And in fact, not everyone feels good when they use an opioid. So many people will talk about the first time they took a painkiller for a medical procedure, they felt kind of nauseous and itchy and dysphoric, and people who have that sort of response are actually protected from having an opioid use disorder. But you can talk to other people who take the same medication and they can describe the first time they tried it, they felt like it was falling in love, or like being embraced in a warm hug, or being in a warm bath. These sort of really mythical descriptions of what the experience was like for them taking that substance. And I think those stories actually highlight the differences in our receptors in our brain, that how we react to opioids depends a lot on our biology. And those biological differences in an individual means that their risk of developing addiction is very different. So early on, for whatever reason someone's exposed to an opioid, whether it's because they're experimenting for fun, they have a co-occurring psychiatric illness that they're using medication to feel better, they're medicating pain, whatever the reason might be, people go from feeling normal to feeling good or euphoric with every episode of use. But what we see is this shift from using to feel good to needing to use just to not feel sick and needing to use to feel better. So people who have a longstanding severe opioid use disorder are not out there having fun, like trying to get high. They literally don't feel normal. They can't function. They can't do the things that they need to do without the drug in their system. And so they get trapped in this terrible cycle of really needing to use just to feel well and just to feel better. And so put another way, this is a quote, again, from a person in recovery, when you can stop, so early on before necessarily addiction is developed, you don't really want to because you haven't started having terrible consequences from the illness. And then when you want to stop, when all the terrible things start happening to you because as consequences of your addiction, you can't because something is different. And so we now understand addiction as this complex interplay between someone's biology, which is about 50% of the equation. So any one person's vulnerability for developing addiction is 40 to 60%. And then the other half of the equation is their environment or exposure or lifestyle. And so this is identical to diabetes or heart disease, where about half of the equation is your family history and what genes you were born with. And the other half of the equation is how you eat, how you exercise, how stressed out you are at work, whether or not you smoke, what your environment is like. So it's the same as many other chronic illnesses. And then obviously with addiction, you have to actually be exposed to the substance, to drugs or alcohol to develop addiction. And then we know that that exposure, particularly in vulnerable people, further changes their biology. It actually changes the structure and function of your brain. And so it's that confluence of events, sort of the genetic risk, the environmental risk, and then the exposure that leads to the illness that we recognize as addiction. So addiction is defined as a primary chronic brain disease that's characterized by compulsively using a drug despite bad things happening to you. So there's a couple important points in there. So first, this is a primary illness in and of itself. So even though it frequently co-occurs with other psychiatric illness, it's its own separate disease and entity. And for most people, this is a chronic illness, meaning it's something that they're not going to be cured from, but the goal is to get them engaged in treatment and into remission, the same way we would think about with any other chronic illness. And then I think the most important thing to understand about addiction is this definition, that it's defined by compulsively using a drug despite bad things happening to you. So why is that so important? Well, for one thing, it's why it can be so confusing for the public or for people, loved ones or family members, when they're trying to understand what's going on with a person who's suffering from addiction. Because it's very easy to look at someone in the throes of active addiction and to think, why don't they just stop? Look at the terrible consequences in their life. They've, just been in the emergency room. They've just lost their child. They've just been incarcerated. If I were in their shoes, I would just stop using. And I think sometimes it's tempting to sort of feel that way when you look at the devastation that addiction can bring. And yet the defining hallmark of the illness is the inability to do that. The changes in your brain that happen in severe opioid use disorder or severe addiction are such that that person can no longer willfully decide to make that choice. And so that truly is the hallmark, and it's essentially manifested as what looks to everyone else like very irrational behavior. The other reason why I think this is so important is that if we think about our systems of care, in the past, we've really tried to punish people into getting well. And that's been our sort of approach as a society, is the notion of sort of letting people hit bottom and tough love, and this idea that if we just make it harder on people, they're going to get better. And yet if the illness is characterized by continuing to compulsively use drugs despite bad things happening to you, making more and more bad things happen to you often is not the solution to getting people well. And really treating this like any other chronic illness with compassion and science and helping people is a much more useful strategy to help them recover. And so that's why it's so great to see many partners in that effort to bring compassion and evidence-based care to people. Because this is a chronic illness, relapse or recurrence is expected, just like with any other chronic illness. So relapse is not a sign that the person has failed. It's not a sign that they won't get well. It's simply a sign that treatment needs to be modified or adjusted. And we already talked about how genetically inclined this is. So what else do we know about addiction? We can actually use functional imaging now to see the ways that substance use disorder is very similar to other chronic illnesses. So on the left side of the screen here is a picture of a healthy heart. So we're doing what's called functional imaging, which basically means we can take pictures of your organs and actually see how the organ is functioning. So you get an infusion of usually a sugar solution, and then we look at the metabolism in that part of your body. And so here we're looking at the metabolism of your heart muscle, and you can see in a healthy heart muscle, it's sort of bright rainbow colored throughout the U-shaped heart muscle. And next to it, you see the heart of someone who's had a heart attack. And you can see that there's an area of the heart that's now not lighting up anymore. So that part of the heart has been replaced by scar tissue, and that injury leads to the chronic illness that we recognize as congestive heart failure. But we actually see very similar things when we look at functional imaging of the brains of individuals with and without addiction. So the left picture on the right is a healthy brain, someone without an addiction, and you can see that the brightest part of the brain are actually our frontal lobes, that sort of top part of the brain. So our frontal lobes are the part of our brain that allow us to kind of put the braking system on our deeper urges and instincts. So it's the part of your brain that allows you to think about risk and benefit and to think about delayed gratification and to weigh consequences when you're thinking about actions. It's a part of the brain that develops last. It takes until about age 26 to develop, which is why if you have teenagers at home, you may wonder sometimes why they can't think about the consequences of their action, and that's why. And so what happens in addiction is you essentially get this mismatch. So you can see next to the healthy brain, the brain of someone with active addiction, and those frontal lobes are no longer lighting up. And so in someone with severe active addiction, it's like your foot is on the gas and the brake is no longer working. So those deep instincts to do something that feels good and makes you feel better has gone sort of into overdrive, and your ability to think about consequences and to sort of make rational decision making has been diminished by active substance use. So that brain that's so injured on the right is similar to the heart that we see that has congestive heart failure on the left. And so we wouldn't expect that person with that heart to be able to just choose to have their heart pump harder, right? We would recognize that they have a physical injury to the part of their body that controls that action, and that what they need is medical treatment. And so similar when we think about addiction, once someone's brain has been injured by active ongoing addiction, they can't make a willful choice to simply stop. They really need ongoing treatment and recovery. But the hopeful news is that unlike a stroke or a heart attack, we actually see those changes get better for the most part. So this is a study now looking at someone with methamphetamine use disorder. And you can see again on the left is a healthy brain where kind of the bright rainbow red color is good normal function. In the middle is someone with methamphetamine use disorder where you can see that, again, you don't see any red anymore. You see diminished function in the brain. And then next to it, you see the brain of someone who's in remission, who's in recovery. And you can see that those changes have normalized. And so in fact, many of the changes that we see in active active addiction do normalize and people return to sort of normal brain function. However, in this study, it took 14 months of treatment and recovery for those changes to normalize again. And the brain in the middle that still looks so injured is actually the brain of someone who's been sober for a month. And so if you think about our treatment system, where people are lucky if they get a few days of detox or a few weeks of care or even a few months of care, and then they're often sent back out and expected to somehow be well again, despite the fact that everything we know from science shows that people need years of treatment before they're truly in long-term remission and have a diminished risk of relapse. And so we've been blaming people for ongoing relapse and for sort of failing treatment, when in fact the entire system that we've designed is mismatched to what we know about the illness. And so if we begin to think about what does it look like to care for chronic illnesses, we can begin to see how our system is just failing people. And so expecting that person after 30 days of treatment to somehow be well again without any ongoing support would be like taking someone with, type 1 diabetes, giving them a month's worth of insulin, and then sending them home with no follow-up and expecting them to somehow control their blood sugar. And so really, as we think about how to fix the problem, I would encourage us to think about system solutions. And so as we start to recognize that addiction really is a chronic illness like so many others, we can also see that it's actually a very good prognosis disease. So treatment outcomes for addiction are as good as any other chronic illness. It's just that we've been expecting these sort of fast miracle fixes rather than thinking about it as a disease that needs long-term ongoing recovery and management. So if you think about high blood pressure treatment, we would expect that people would have high blood pressure before they started treatment, and that with treatment, most people actually respond to therapy and their blood pressure comes under control. And if you all of a sudden stop treatment, you'd expect that they would have a relapse, that their blood pressure would go up again. And yet with that person, we would look at that individual and say, oh, you need more treatment, or we need to modify your treatment plan. And yet we see the same thing with addiction treatment. So with good treatment, 40 to 60% of people will be in remission at 1 year, and those numbers go up the longer treatment goes on. And if you stop treatment prematurely, a significant number of people will experience a relapse. So what is effective treatment? So for opioid use disorder in particular, I really think of treatment in sort of 3 buckets. So the first is pharmacotherapy or medication treatment, and we'll talk a lot about that today since that's sort of the purpose of today's training. And for opioid use disorder, we have 3 FDA-approved medications. So when we think about substance use disorders broadly, we have good effective medication for tobacco use disorder. So many people are familiar with nicotine replacement therapy or with other medications that people take that significantly increase the likelihood that you can stop smoking. And we also have medication treatment for alcohol use disorder, and then very effective medication treatment for opioid use disorder. The other bucket, the other sort of component of treatment, are psychosocial interventions or behavioral treatments. So this is sort of what we classically think of as therapy. But when you think about what works for people with opioid use disorder, it sort of falls into 3 camps. One is really skills-based training. So this isn't lying on the couch kind of talking about your childhood. This is really focused on skills. So cognitive behavioral therapy is all about separating your thoughts from your actions. So recognizing that thoughts that happen don't have to lead to a certain action, and helping people build up their toolkit so that they have other tools to cope with stressful circumstances, and that they can begin to identify high-risk situations for themselves to actually prevent relapse before it happens. Motivational interviewing or motivational enhancement therapy is another type of therapy that's really all about resolving someone's ambivalence and helping them engage in treatment. So one thing we don't often talk about is that one of the hallmarks of addiction, and particularly when you're starting to first encounter someone, is ambivalence. So what does that mean? Ambivalence basically means wanting 2 things at once. So pretty much unanimously, people who are experiencing addiction, who are first engaging in care, both want to be able to continue to use and want to stop using. And we often, I think, people feel badly for feeling that way. They feel like they're supposed to not want to use drugs, and we often misinterpret that as people are lying to us. So frequently we'll talk to doctors and they'll say, my patient lied to me. He told me he didn't want to drink anymore, and then he went out and drank again. And it's like, no, he wasn't lying to you. He really didn't want to drink anymore, and at the same time he wanted to be able to keep drinking. And that's sort of a hallmark of early recovery and early engagement. And so motivational enhancement therapy is really about helping people resolve that ambivalence and helping engage them in care. And then contingency management is actually rewarding people for good behavior. So we often do the opposite. We try to punish people for bad behavior, which can be effective, but is not as effective as rewarding people for good behavior. So this is, traditionally in studies, this is giving people gift cards for showing up to treatment or for not using drugs, basically. So they get small little gift cards for appropriate toxicology or for staying engaged in care. So drug court would be a good example of where we think about positive contingencies for helping people engage in care. And then recovery supports is the other piece of the puzzle. So this traditionally people think of mutual help organizations like 12-step groups as a type of recovery support, but there are many others. Another example would be recovery coaches, which I know you guys are familiar with here. We have 10 recovery coaches in our system, and they've been really game changers in the care that we've been able to deliver. And this is really about building up the fabric of someone's life and helping them cope with managing a chronic illness. So in the same way that we think about people going through cancer treatment need support, we have cancer support groups, and we have navigators, and we have ways of helping people get through their treatment. People suffering from addiction need the same degree of support. So when we think about treatment, as an internist, so as a doctor who takes care of not just addiction, but also heart disease and diabetes and HIV, I really think of the management of opioid use disorder in particular as very similar to other chronic illness management, particularly things like diabetes or HIV. So as we mentioned, there's no cure, but the goal is to get someone on treatment and to get them into remission, meaning they no longer have symptoms of active disease, and to prevent the acute and chronic complications we know come from untreated illness. So in diabetes, we're thinking about normalizing someone's blood sugar because we don't want them to get kidney disease or to have a stroke or to have any other of the negative consequences that come from untreated diabetes. And with opioid use disorder, our goal is to help someone not use opioids so that they don't have all the terrible consequences like getting hepatitis C or having an overdose or having some other consequence of untreated opioid use disorder. And with diabetes or heart disease care, we have decades of science showing us what's effective and what targets we should aim for in terms of treatment. But we then tailor that plan to the person in front of us. So, if I see a patient in clinic and I really think they should start insulin because their blood sugar is incredibly high, and they say to me, I'm terrified of needles, there's no way I'd ever think about going on insulin, but I'd be willing to take a pill, I'm not going to not offer them a different treatment. I'm going to meet that person where they are and then continue to partner with them towards health. And I think that sort of flexibility in care we really get with other types of disease management. And yet, historically, at least in addiction treatment, we've often had sort of a one-size-fits-all, all-or-nothing approach. You take it or leave it. And if you're not willing to do everything that's required of you in treatment, then we often blame the person. We say that they're not ready or they're non-compliant or something like that. And so I think shifting to think about opioid use disorder care like we do other illnesses, where we really have the person at the center of that treatment plan. And then again, diabetes, HIV care, all of these different interventions usually include some combination of medication, of lifestyle change, of ongoing follow-up, and behavioral support, because it's really hard to change your behavior and to manage a chronic illness. And so that menu of options is the same that we think about when we think about opioid use disorder. The other thing I think we can learn is when we think about past public health crises, HIV actually offers a lot of lessons for us when we think about how to address the current crisis. So if you think about HIV, it was once a fatal diagnosis, and for about a decade, we simply watched the death toll rise without doing anything or having any tools to address it. And yet it's now transitioned to be a chronic illness that for most people is managed with a single pill a day, and actually people are predicting a not too distant end to the HIV crisis. And when we think about how people predict that we're going to eradicate HIV, it's this combination of testing more, meaning identifying people early, getting people immediately on treatment, and then helping people who are at risk safe. And that sort of triple aim, I think, could be applied to opioid use disorder as well, that identifying people early, so not waiting until they've had an overdose and are in an emergency room, but actually identifying them when they're first developing the illness, getting people immediately on treatment, and not making it hard to access treatment, but rather bringing treatment to people, and then helping people who are at risk stay safe. The other thing we can learn from the HIV crisis is the life-saving impact of medication. So the blue line in the beginning is the death toll from HIV-related deaths between 1984 and 1994. So again, for 10 years, we simply watched the death rate rise without making any progress. And then something happened right before 1996 where we saw the death rate plummet. And it was the discovery of life-saving medication, where all of a sudden people could take medication daily that would keep them alive and keep their disease in remission. And so we really, in the HIV epidemic, had to wait for science to discover that. We needed biomedical breakthroughs to come up with the medications that were going to save people's lives and keep them healthy. And so the good news with opioid use disorder is we actually already have medications that are every bit as life-saving as medications in the HIV epidemic. And so the graph on the left is looking at Baltimore, Maryland, and the red line is heroin overdose deaths in Baltimore. And the dashed green line is access to a medication called buprenorphine, that you may know as Suboxone is the trade name. And the blue line is access to methadone. And what they saw is that as access to medication treatment increased across Maryland, there was a 50% reduction in heroin overdose death rates. The graph next to it is actually from the country of France, where any doctor can prescribe buprenorphine, so there's not sort of special requirements around who's allowed to prescribe it. And they were able to get 90,000 patients treated in less than a decade and saw an 80% reduction in heroin overdose death across the country. So on a personal level, the World Health Organization estimates that if a person takes their medication, their risk of dying drops by 90%. So when you think about how to keep people alive, one of the crucial components of our intervention has to be getting people life-saving medication. So just to touch a little bit more on that, so that's that bucket of pharmacotherapy, and I mentioned that there's 3 FDA-approved medications. So what are the 3 treatments and how are they different? So the oldest medication is medication methadone that was discovered in the 1960s, and it's what we call a full agonist, and just kind of a brief pharmacokinetics primer on what that means. So what that means is basically it sticks to the same receptor in your brain that other opioids do, and the more you take, the more effect you get. But it has a slow onset of action, and it lasts for a very long time. So people can take it once a day, and it'll last for the entire day, whereas someone who's using heroin or fentanyl is using 3, 4, 5 times a day and is constantly sort of chasing the feeling of trying not to be sick any longer. Methadone was actually discovered by an endocrinologist in New York, so a doctor who specializes in diabetes care or other types of endocrine issues, and he sort of stumbled upon this as a treatment for heroin addiction, and they published the first paper in one of our leading medical journals in 1965 and described these really sort of amazing results of a group of very sick men who were unemployed, mostly homeless in New York City, in and out of jail, unable to work or have any relationships using heroin, and they started treating them with methadone, and after a few weeks of treatment, they noticed that all of a sudden the men weren't having this constant daily obsession with needing to use or feeling this intense craving or urges. And over time, they started being able to work again and have relationships again, and they weren't getting arrested anymore. And so they published those first findings in 1965, and the doctor who discovered it, I think, really came to understand opioid use disorder is similar to other types of endocrine problems. So if you think about diabetes or underactive thyroid, if you have any family members with that, or adrenal insufficiency, there's many conditions where with a severe form of the disease, you actually need a chemically similar medication to get you back to a normal level of functioning. So that's in essence what we're doing with diabetes care is your body no longer produces enough insulin, and so we actually give you back the same molecule that you're missing so that your body can function normally again. And so that was how this doctor really came to understand methadone treatment for opioid use disorder. Methadone is still considered the gold standard worldwide in terms of being the most effective treatment we have for opioid use disorder. But in 2002, another medication was approved by the FDA, which is buprenorphine, which is that medication that the trade name is Suboxone. And so buprenorphine is very different. It's what we call a partial agonist. And so what that means is that it sticks to that same receptor, but it has only a partial effect. And at a maximum dose, the effect flattens out. So you see what we call a ceiling effect. And what that means is that once all of your receptors are saturated with the medication, even if you took 20 more tablets that day, you wouldn't feel any more effect. And so that makes it basically impossible to overdose on buprenorphine, and it means that it has much fewer side effects. So one of the downsides of methadone is that for some people at very high doses, they can feel sleepy, they can have constipation. At very high doses, you can experience an overdose, so there can be dose-limiting side effects. Buprenorphine has that ceiling effect, and so it makes it much safer, and which is why it's allowed to be prescribed in a doctor's office rather than in an opioid treatment program. So one more sort of tool in our toolkit when we think about treating opioid use disorder. The third medication is naltrexone, that you guys may know by the trade name Vivitrol. Comes as an injectable medication that's given once a month. And that's just a pure blocker. So what that means is it sticks to your receptors and just prevents you from being able to have any effect from other opioids if you were to take an opioid. So that sounds really great in terms of sort of a relapse prevention tool. But unlike the other medications, if you think about sort of that cycle I showed you where people shift from kind of using to feel good to needing to use just to get normal again, if someone doesn't feel normal unless their opioid receptors are activated a little bit, naltrexone's not going to have that effect. And so for many people who have very severe opioid use disorder, it isn't as effective in terms of craving reduction as other 2 medications. But again, all of these medications are important and available, and really deciding what's right for which patient depends on the clinician's assessment and the individual patient in front of you. So just to highlight for the 2 medications, methadone and buprenorphine, the goal is to get someone back to normal. So if someone's on an appropriate dose, they should have a stable effect where they don't appear intoxicated, they don't appear over-sedated, but they're not in withdrawal, they're not having cravings, they simply feel normal again and are able to function. So when we think about the overarching goals of medication treatments for addiction, the first is to relieve withdrawal symptoms. So withdrawal from opioids is incredibly painful and debilitating, and that sort of sickness and fear of withdrawal and the constant daily withdrawal is part of what keeps people trapped in the cycle of using opioids. So the first goal is to get someone comfortable and relieve their withdrawal. The next step is actually blocking the effect of other opioids. So all three medications at appropriate doses, if you use another opioid on top of it, you don't actually feel the effect of the other opioid. So we know, again, that this is a chronic illness, so people will experience relapse. They will use over the course of their period in recovery. But if they've taken that medication that day, they won't actually feel the effects. They won't be able to get high. And so that in and of itself is sort of a relapse prevention tool, because patients will say, I took my buprenorphine today, I know I can't use, it'd be a total waste. And so it helps sort of reinforce that daily abstinence, even when there are moments where someone might be in a situation where they would be triggered to use. The third goal is reducing cravings. So withdrawal symptoms are one of the things early on that keep people using opioids. But over the long haul, when we think about why relapse rates are so high even after withdrawal management, it's really ongoing craving, which is this strong, incredibly powerful psychological urge to use. And so one of the main goals of medication treatment is to diminish cravings so people aren't constantly driven every day by this strong urge to want to use. And then the last goal, and this really happens over long-term treatment, sort of 6 months and longer, is to restore the normal reward pathways in the brain. So when we think about the changes that happen in someone who's using opioids or using any other addictive substance, the sort of release of chemicals that happens when they use that drug is so powerful, the sort of release of dopamine and all of the feel-good chemicals that we think about in our brain, that other things that cause people without addiction to feel, to activate their reward system. So, going for a run or eating something delicious or human contact, those seem less pleasurable compared to the drug. And so there's this sort of changes in the reward pathway in someone who has severe addiction. And so part of the goal over long-term treatment is that we actually see normalization of those changes in people who are treated with medication. The other reason why we talk about ongoing treatment with medication is because of what the science shows us. And so what do we know from research studies? Well, the first is that detox alone is completely ineffective. So there's never been a single study that's shown that detox alone helps people stay off opioids. This was one of many studies. This is done out of Johns Hopkins University, where they took people who had completed an inpatient detox and then looked at what happened to them 30 days later. And more than 80% of people had relapsed to opioids 30 days after detox. In fact, 26% used the day that they left detox. So when we think about effective interventions, detox is not an effective intervention. And in fact, it can be quite harmful if that's all that someone gets, because what you essentially do is you remove someone's tolerance, so their ability to handle the amount of drug that they've been using, without actually increasing the likelihood that they're going to not use again. And so when they predictably go back to using, they're at greater risk of dying from an overdose because they don't any longer have tolerance. So what is effective treatment? So if I told you for any other illness that we had one treatment where with it no one would get into remission, and actually 20% of people would be dead at 1 year, or another treatment strategy where 75% of people would be in remission at the end of 1 year and no one would die, you probably would want treatment A, I would guess, rather than treatment B. And you'd also think that this would be sort of in the headlines. And yet this is a study that was actually done in 2003 where they took people in an inpatient facility and they randomly assigned them to either get detox plus a year of intensive psychosocial counseling, or be put on buprenorphine daily for a year with intensive counseling. And they found in the detox arm exactly that. So no one stayed sober, and actually 100% of people experienced a relapse before falling out of the study, and 20% were dead at the end of 1 year. In the treatment group, 75% were still in care, 75% were totally abstinent, and no one died. So really dramatic differences between these two strategies. There have been dozens and dozens of studies looking at different types of medication treatment for opioid use disorder. This was one that looked at a longer-term detox, because early on the thought was, well, maybe it's just short-term detox that doesn't work. So this is actually a 180-day long methadone detox compared to staying in methadone maintenance treatment. And so you can see the solid line is people who detoxed, and right away they start falling out of care. So they kind of drop off that cliff and aren't engaged in care anymore. And then the dashed line is people who are on methadone maintenance, where at the end of a year, about 80% of people were still engaged in care. And then once they stopped the medication, those people fell out of care as well. So again, thinking of this as a chronic illness, long-term ongoing care is really the effective strategy to keep people well. We also know from what are called meta-analyses, which is basically scientists take a whole bunch of studies and they pool all of the results, and so it allows you to get a much larger sample size to look at many, many more subjects who've been in studies. So this is a meta-analysis looking at a number of studies comparing methadone treatment to other types of non-medication treatment, and found that people on medication treatment actually used opioids at 44% lower rates than people who were in non-medication treatment. So improves retention but also reduces opioid use. And then the other thing we know about not having access to treatment is that people die while they're waiting for treatment. So we often think about sort of the frustration of being put on a wait list and what a hassle it is that treatment isn't immediately available, but it's actually killing people. This was a study in Norway looking at people on a wait list to get into methadone versus those who were accepted, and they were 10 times more likely to die if they stayed on a wait list than if they were immediately accepted into treatment. Another study came out last year that again looked at a huge number of people. So this was looking at almost 16,000 people treated with buprenorphine over a range of about 1.5 to 4.5 years, and found that when people were on the medication, when they're engaged in treatment, their risk of dying from an overdose was about 4 times lower than if they stopped the medication. So really dramatic differences in terms of the death rate. When we think about not just death outcomes, but also cost outcomes and relapse outcomes, this is a study of Mass Health members, so here in Massachusetts, comparing those who are on medication treatment versus those who went to behavioral types of treatment where medication wasn't available, and found that being on medication reduced the risk of relapse by 50% and reduced costs on an individual level by about $150 to $220 per person per month over the course of the study. So cost effective and also reduces relapse rates. So what about naltrexone? So naltrexone is also an important tool to have in terms of our thinking about the 3 types of medications that we have. And for a long time, we didn't have any comparison studies that actually directly compared extended release naltrexone to buprenorphine in terms of thinking about the relative effect of those two. Recently, there was a first ever US head-to-head trial that compared those 2 medications. And what they found was that right out of the gate, it was harder for people to get on naltrexone, which for folks who work with people in the community, that probably won't come as a surprise because you need to be off of all opioids for 7 to 10 days before you can take naltrexone to start with. And so if you think about an illness where people generally can't go a day without using, it's really hard to get to that point. And so when you compared sort of all comers who were randomly assigned to either get methadone or buprenorphine or naltrexone, the group that got buprenorphine was much more likely to stay sober and was able to stay sober for a longer period of time than the group that got naltrexone. But if you look just at people who actually made it on the medication, the 2 were equally effective. So people who are able to get on naltrexone effectively and who want that treatment, it seems to be a very effective tool to have. But when we think of all comers and you're sort of randomly assigning people to treatment, buprenorphine seems to be more effective. So if I've shown you all of this evidence, why is it that treatment often looks so different than what we've just talked about? And I think that's really where some of the stigma comes into play as we think about sort of ongoing efforts around opioid use disorder. And we have to remember that for 100 years as a society, we've really thought of addiction as an issue of morality and of choice and of bad behavior, and something that should be dealt with by punishing people and putting them in jail, et cetera. And so I think despite all of the changes in our conversation, many people still sort of think that people with addiction should just knock it off and should just pull themselves up by their own bootstraps. And that's led to really, unfortunately, poor decisions around treatment allocation. We continue to hear people talk about short-term detox as being an effective strategy, despite the fact that it's never been shown to actually be helpful. So what do we know? Well, the science, as I hope I've shown you briefly, is really clear that medications for addiction treatment work. This is from the Surgeon General's report on alcohol, drugs, and health that came out in 2016. And as he points out, there really is no debate in the scientific community, and yet there continues to be a lot of confusion, misunderstanding, and outright stigma about the use of medications. And probably the sort of most persistent notion is this a sort of confusion that you're just addicting someone to a different drug, that you're just substituting buprenorphine for heroin, and someone's not really in recovery, they're just addicted to something else. But if you think about the definition of addiction, which again is defined by compulsively taking a drug despite bad things happening to you, taking a medication every day that's prescribed by a doctor that allows you to function and feel normal and work and parent, does not meet the criteria of addiction. If it did, we would all be addicted to our blood pressure medication, our cholesterol medication, our insulin, or the other medications medications that we need to stay well from chronic illnesses. And so I think that confusion, that misunderstanding about what really is addiction, it's not the presence or absence of a medication, it's whether or not someone is compulsively using a drug and having bad things happen to them in their life. I think other countries have gotten this a little bit quicker than we have. This is actually the World Health Organization's guidelines from 2009, so almost a decade ago now. Their guidelines, they called them actually the psychosocially assisted pharmacotherapy guidelines. And they did a huge review of all of the existing data and came to the conclusion that of all of the available treatments, opioid agonist medications are the most effective treatment we have with psychosocial services. But they make the point that even if someone doesn't want to take the psychosocial services, they shouldn't be denied life-saving medication just because they're not willing to sort of take the entire bundle, and that we really need to make these medications available, particularly when we think about keeping people alive. The other thing that's important to note as we think about this as a chronic illness is that treatment really needs to be long-term. So we're talking about treatment over the course of years, not weeks and not months. And it takes that sort of long-term treatment before people are able to maintain their remission without ongoing relapses. And that we should really be celebrating people for staying in treatment long-term rather than making them feel like they should kind of be better already or they should come off their medication already. But really, the goal is health and recovery, and engagement and care is actually a wonderful pathway to get there. We also know when we think about kind of long-term outcomes, that outcomes are actually incredibly good. So this is one of the longest studies we have looking at buprenorphine in particular. So this was a big randomized controlled trial across the country looking at people with prescription opioid use disorder who were given buprenorphine treatment. And then it followed half of that group for 42 months, so almost 4 years long. And at the end of 42 months, only 8% of people still met criteria for active addiction. So 92% of people were in remission. So this is an incredibly positive outcome, and I think we don't talk about this enough, that most people with this illness will get better, and that recovery rates are incredibly high when effective treatment is offered. And so, I think we are so inundated sometimes with the terrible news of more and more deaths and of the suffering and sort of devastation of addiction that we sometimes forget this message of hope, that treatment is out there, treatment works, and that most people will get better. The other thing is that treatment takes time. So, overnight fixes often don't happen with any chronic illness, and certainly not with opioid use disorder. And so this is a study that followed people for 60 months, looking at methadone or buprenorphine versus no medication treatment. And so no medication is on top. You can see that those folks don't do as well as being on medication treatment, but you can also see that there's a very gradual improvement. So early on, when people are first engaging in care, there was a reduction from using every day to using only about 5 days out of the month. But still, if you think, often we think of things in black and white terms as sort of sober or not sober, and too often in treatment programs, sometimes people are actually kicked out of care if they continue to use. And what we know from research is that actually early on, continued use happens, but the goal is that it's happening less and less frequently, and that if you stick with that person, keep them engaged in care, that actually over time most people achieve total abstinence, meaning not using any substance, total remission. We also know that treatment can be effectively delivered in lots of different care settings. So they've studied doing this in primary care. So many patients say, I don't want to go to some specialty place to get my treatment. I want to get my treatment in the same place I get my diabetes care or my high blood pressure care. And in fact, treatment outcomes are as good when addiction treatment is offered in primary care as when it's in a specialty setting. And so this was a trial that looked at getting medication management by your primary care doctor. So getting your buprenorphine and counseling in that single visit with your doctor, versus getting that plus specialty counseling on top of it, and actually found no benefit of the additional specialty care. So it's not that counseling isn't important, but that actually can be done as a part of a medication visit with a physician in the office. And so really making sure we have lots of different pathways to treatment and that treatment's available in lots of different care settings. Increasingly, we've recognized that hospitals have an opportunity to initiate treatment, and I know you guys are partnering with local hospitals, which is really fantastic. There are 3 big studies that really highlighted the opportunity we have when someone's in the hospital. The first 2 were done out of Boston Medical Center. The first, they took all comers to the general medical service, so these were not people that were saying they wanted to start treatment or that they wanted to stop using. They were there because they had an abscess or they'd had an overdose or some other medical reason, and they offered them to start methadone in the hospital and then get linked into care. And they actually actually found that if they started methadone in the hospital, 82% of people would present into follow-up addiction care. So that's incredibly high, especially for a group that was not so-called treatment seeking. They weren't coming in asking for help. So that led them to actually do a randomized controlled trial where they took, again, all comers to the medical service, and they randomly assigned them to either get detox with buprenorphine while they're in the hospital with a referral to ongoing care in the community, or to actually start the medication in the hospital and continue it. And they found that if you started the medication while someone was in the hospital, 72% of them were still in care, versus if you detox someone and referred them, only 12% made it into care. So that sort of seamless continuation of starting treatment in the hospital bed and then linking people directly into care was much more effective. So a group at Yale actually took that a step further, and they said, well, why don't we do this in the emergency room? So they took all comers to the emergency room, and they randomly assigned them to 3 groups and basically looked at starting buprenorphine in the ED and giving someone a 3-day prescription to get them into ongoing care in the community, versus simply referring them to care from the ED or doing sort of a motivational intervention in the ED, and found that for the folks that started medication in the ED, 78% were still in care a month later, compared to 37% of the group that got the motivational intervention plus the referral. So that was a huge study in terms of sort of influencing a lot of the conversation that's been going on around emergency department care and what opportunity we really have when people are showing up there. We also know that treatment can be done in lots of other settings. So treatment in correctional facilities is absolutely effective in terms of medication treatment. So many other countries offer methadone and buprenorphine in prisons and jails, and that's not something that's been widely adopted in the US. Our neighbors to the south, Rhode Island, now is the first state to offer all 3 types of medication treatment in all of their correctional facilities, and they just published a paper last month showing a 60% reduction in overdose fatality after release from prison since they started that program. So really exciting and promising results out of Rhode Island. And then other models are actually bringing treatment to people. So we just started a mobile van in Boston that's bringing treatment out onto the streets of Boston, going to hotspots where people are overdosing at high rates. And this has been studied and shown that when you make treatment mobile, when you actually literally drive treatment to the people, you're able to access people who are at higher risk, so people who are less likely to have engaged in treatment before, racial and ethnic minorities, people who are uninsured, people who are actively injecting, than if you expect people to come to treatment. So really thinking creatively and flexibly about how we make treatment available to people in lots of different ways. And yet, despite all of that, most of what we've just talked about is not widely available. So, most primary care offices are not offering buprenorphine. Most hospital EDs are not offering treatment initiation. And so there really has been this huge lost opportunity. And I think part of that is because for a long time, doctors weren't trained on how to treat addiction. And most of us felt like, well, that's something that someone else does. Addiction treatment happens elsewhere. It doesn't happen in the medical system. And so we're really beginning to try to undo that. But that's a lot of history to try to undo, and trying to retrain people to be able to actually offer this care. And so if we look across, this is a 2015 survey looking across the country at all different types of doctors, and found that of all doctors, only 2% actually were able to prescribe buprenorphine. So if you think about the fact, 500,000 people are dying from this illness, that we have an effective treatment to save people's lives and keep them well, and yet 2% of doctors are actually able to offer that treatment. If you look across the country, we're actually very well resourced in Massachusetts, but 50% of US counties don't have a single doctor who can offer this treatment. So there are huge gaps and treatment deserts across the United States. And even areas with buprenorphine prescribers still have access issues. So you may have been familiar that Congress actually passed an act in 2016 to increase the number of patients that a single doctor could care for. But if you actually look at Massachusetts, the average number of patients that a doctor who's prescribing buprenorphine in Massachusetts cares for is 22. So doctors are nowhere near their caps. I really don't think it's an issue of caps or of expecting a few doctors to care for hundreds of patients, but rather that this should be a treatment that's widely available and that all doctors offer to patients of their own that need help in the office. And so that really gets to this sort of need for change at the physician level too. And I think sometimes we forget that doctors are society members too. We're just as strongly influenced by stigma and by our history around sort of thoughts and notions about drug use and addiction as anyone else. And so this quote really highlights that this sort of historical attitude that people with addiction have somehow brought their suffering upon themselves has influenced our policies and our public health approaches to addiction. And even as we start talking about this as being a disease, there's still this idea that, people have done something wrong, and so we shouldn't make it too easy on them. We should sort of make it a little hard. And I think, the mere existence of treatment that's effective and all of the research that supports it hasn't been enough to change the system. And until we can address these stigmas and these underlying misperceptions and false notions, I think that's one of the key things that needs to happen to change our system. So what does care currently look like for someone in the medical system? Well, often, unfortunately, people are blamed for their condition. So, I hear of people who go to emergency rooms after an overdose and are treated poorly and are released immediately to the street, or if they're lucky, they get a list of programs to call, or people who have infections of their heart valve and aren't offered a surgery because they did this to themselves, or they inflicted this condition on themselves. And there's a lot of blame and shame, whether it's overt or inadvertent, that just gets communicated to people with substance use disorder. And so what could it look like if we thought about person-centered care for opioid use disorder? Well, it would look like care for any other illness, where the person is at the center of that, and where at every encounter with the health system, treatment would be available to them. So if that's in the emergency room, if they're hospitalized, if they're in their primary care office, if they're at a nursing home getting well after a hospitalization, or even in the pharmacy, that there's so many different touch points with an individual where we can offer life-saving treatment. And if you add into that the community touch points, or touch points with the criminal justice system or with other social service agencies, there are many, many interactions that people with this illness are having with all different components of the systems that we've built to try to support people. And if we make treatment the easy choice and readily available, we can begin to get our arms around this crisis. So when I think about sort of what's my checklist for what good care looks like, because this is something I'm often asked by people who are in the community and trying to help someone get into care, and they don't necessarily know, what to look for in a program and to know if it's a good program or not. So first is whether they have immediate access to all three types of medication. And that doesn't mean that every person with opioid use disorder needs medication. There are definitely people who recover without medication, and that's fantastic. There are people that recover from diabetes without medication too. But we would want a diabetes treatment program to have the ability to offer insulin, or we'd want a cancer treatment program to offer chemotherapy. So if someone's going to be holding itself out as an addiction treatment program, they should be able to offer life-saving medication treatment that we know is effective for many people. Next is that treatment should be based on the person. So any time I hear about sort of a one-size-fits-all, that every single person gets exactly the same sort of list of interventions, that always makes me a little bit concerned, because when we think again about medical interventions, we tailor those to the severity of the person in front of us, to the realities of their other illnesses or their life, and so we don't have sort of a one-size-fits-all approach, but we really individualize that to the person in front of us. So I'm really looking at, are they assessing each individual person and offering them care based on their personal experience in their illness? And then lastly, and perhaps most importantly, what does a program do if someone has a recurrence of their illness? So, if you're in the hospital because you've had a heart attack and you have more chest pain, you're not going to get kicked out of the hospital. And yet still, in treatment programs, if you have a symptom of your illness, you get kicked out of treatment. And so, I think that really is an unacceptable response to ongoing sickness, when we need to be intensifying care and wrapping our arms around a person. And so that's another sort of thing that I'm always watching out for. This was a pledge that the Surgeon General sent to every physician across the United States in 2016. I think it also offers a nice kind of big picture approach to the current crisis of opioids. So he asked all doctors to take a three-pronged pledge. So first, to educate ourselves to treat pain safely and effectively. Second, to screen patients for opioid use disorder and provide them with evidence-based treatment. And third, to talk about and treat addiction as a chronic illness, not a moral failing. So pretty simple, but really hits kind of the high points when we think about responding to the current crisis. Another important piece for everyone, not just for health professionals or but for community members, for anyone who's even talking about addiction, is really being thoughtful about the language we use. So a lot of the words that we use when we talk about addiction are very different than language that we would use for any other medical illness. So take the word abuse. You often hear people talk about people as being substance abusers or drug abusers, and that's not a word we would use for any other illness. So we don't say that a person with an eating disorder is a food abuser, or person with diabetes is a sugar abuser. And the word abuse actually means a willful act of misconduct. So we're literally communicating to people with our words that we think they're to blame for their illness. And that may sound a little like PC, or that it's just an issue of semantics, but they've actually studied this. And if you take highly trained professionals, so PhD or master's level therapists, and you give them a description of a patient, and the only thing you change is the word substance abuser for person with a substance use disorder, the therapist is more likely to recommend punishing treatment for the person described as a substance abuser. So language actually influences our clinical decisions and is incredibly important. Other words that, again, we wouldn't use for other conditions, clean and dirty. So we don't talk about people's blood being dirty with cholesterol or anything else. There's a strong implication, even with clean, which is a positive term, you know, the implication is that if someone's actively using, they're dirty. So really trying to move away from some of the language that we've used in the past and to use medically appropriate and what we call person-first language. So person with addiction or a person with a substance use disorder rather than an addict or an alcoholic. And, you know, that recognizes that people are more than their illness. So we don't talk about the breast cancer or, you know, the heart disease. We talk about a person who has an illness, but it doesn't define them. It's not all about who they are. So with that, I want to shift in the last little bit of this formal talk to talk a little bit about what we've done at MGH and our sort of journey in trying to redesign care. So back in 2014, we launched what we call our Substance Use Disorder Initiative. And it was really an effort to take all of the evidence that we've talked about this morning and begin to actually integrate it into our medical system. So recognizing that we were starting from a place that also looked very different from what the evidence shows, where we had specialty addiction treatment, but it was quite hard for people to get there, and most patients never made it. We didn't have treatment available at every intersection with a healthcare system, and there was still a lot of stigma amongst our providers and our healthcare staff. And so in 2014, we started a process of trying to change that and trying to think about what would it look like if we made treatment the easy choice and made it readily available in every encounter with our system. So we started an inpatient addiction consult team. So in the hospital, a patient who comes in with a substance use disorder can see a team of specialists in the same way that if you have a heart attack, you'll see a team of cardiologists. So our team is available across the hospital. We have a 1,000-bed hospital, so we see lots of consults. We can start medication treatment in the hospital. We have 4 social workers who do wonderful bedside motivational work. We have a recovery coach. We have lots of trainees. We have nurse practitioners. And so we can sort of utilize that hospitalization as a reachable moment to start treatment and then to connect people into ongoing care in the community. From the start, we recognized that even if we did a lot of effort around changing our own care system, there are many gaps that still exist outside of our system in terms of care for people with substance use disorder. And so we started what we call our Bridge Clinic, which is essentially an urgent care model drop-in clinic that tries to bridge the many gaps in care. So people can just show up. They don't have to have an appointment. You can come, 3 hours late or 5 days late. You don't have to want to stop using. You don't have to want treatment. Where our goal is really just to try to engage people in whatever way we can. So about 50% of our visits are not scheduled, meaning people just show up. We have coffee, we have snacks, we have clothes and transportation vouchers, and a really welcoming team there that tries to meet people where they are and engage with them and then help them begin a process of hopefully starting treatment and connection. And so that clinic can see people leaving the hospital or also see people leaving the emergency room or from other places in the system. In our primary care practices, we've worked to integrate treatment right into primary care. So we've developed teams of addiction champions in our primary care practices that come together weekly or bi-monthly to talk about cases that they're worried about. So the whole team is sort of thinking together about high-risk cases. We've embedded recovery coaches in those practices. So we have 10 coaches across the system. And then we've trained up our primary care doctors to be able to offer medication treatment for addiction, including buprenorphine and extended release naltrexone. I mentioned our recovery coaches. They have been, we call them the human glue of our model. They really are an incredibly valuable resource, and their job description is pretty simple. It's basically to address any barrier to recovery. And often those are things that in the beginning don't necessarily look like they're recovery associated and yet are for sure posing huge barriers in terms of people engaging with treatment. So they help someone get a photo ID. They'll go to court with someone. They'll help them attend their medical appointments. They'll take them to a mutual help meeting in the community. They provide a lot of text messaging and telephonic support. They run peer groups for in the health center so that patients can drop in and get some peer support in the health center environment. But the other thing they do is they really send a message of hope, and they're a constant daily reminder that most people with this illness get better. They're literally, an MJH colleague wearing a badge, joining in all of our clinical discussions, and they're a person in long-term recovery. And so that in and of itself goes a long way towards fighting stigma and really reminding us all of that hopeful message. And then the newest piece that isn't even on the slide, but that you heard mentioned, is that we're now offering treatment to start in the emergency room. So we've trained up the vast majority of our emergency docs. So there's 24/7 a doctor on staff who can prescribe buprenorphine, and we're able to actually start treatment in the ED and then link people directly into the Bridge Clinic for ongoing care. We've studied this model in a number of different ways. We've looked at patients who are seen by our addiction consult team. We've done over this now, probably close to 5,000 consults. In the hospital, actually, our most common consult is alcohol, and then the second most common is opioids. And our patients are about 70% male, average age of around 47. We found that patients who are seen by the consult team are less likely to be readmitted to the hospital. They're more likely to stay abstinent after they leave the hospital, and they are able to stay abstinent for more days out of the month in both the 30 and 90 days after they leave the hospital. Our Bridge Clinic, as I mentioned, is cared for about 600 patients. The idea of the clinic is that it's a transitional model, so patients stay with us as long as they need to until they are able to connect into ongoing care in their community. So on average, people stay for about 2.5 months. I talked about the flexible component of the model, which I think is really crucial. So about 50% of visits are not scheduled. And we found that for people who come to Bridge Clinic after a recent hospitalization, their readmission to the hospital is incredibly low. It's only about 10%, which is lower than even general medical patients. In our primary care settings, so our 10 recovery coaches have had almost 12,000 contacts with 1,200 patients. And we found that being linked to a recovery coach is associated with fewer hospitalizations and with greater engagement in primary care. In our primary care setting, in our 3 health centers alone, we've trained almost 40 doctors to prescribe buprenorphine, and they're caring for about 550 patients. And those teams come together in those case conference meetings I mentioned that we call risk rounds, which are an opportunity to talk about high-risk cases. And then all of our health centers are partnered closely with our community-based coalitions, and so members from those coalitions actually join us in those interdisciplinary team discussions. And then this is our ED-initiated treatment. So if you're on Twitter, you can follow us at @GetWavered. And this was around really sort of changing physician behavior and encouraging them to want to take this on as a tool that they offer to patients. So where are we going from here? So in April, next month, we're opening a family clinic that we're calling the Hope Clinic, which will be a clinic for pregnant women and their partners that will follow the family unit through the first 2 years of the child's life. So one thing we know is during pregnancy is a really motivating time for women, and then after the child is born, often the bottom drops out. And so across the state, we see really rising rates of overdose in the 6 to 12 months postpartum for women. And so our hope is to really build a bridge under the family that lasts for the whole first 2 years of the child's life to try to support the family unit in getting their addiction care, their medical care, their pediatric care, their psychiatric care all in one site. We're continuing to integrate our care system across primary care. We're providing mentoring to new buprenorphine prescribers, so new docs that feel nervous about taking on this new type of treatment can be paired with an experienced doctor who can offer them support over their first few cases. And then this year we're starting our first addiction medicine fellowship, which is a specialty training program for physicians to become specialists in addiction medicine to try to build up the pipeline of other doctors. So that is my formal talk, and I look forward to questions. I'll end with this quote. This is a part of my passion about language. Another term I hate is the term enabling, and this idea that if we're somehow kind to people who are using drugs, that we're doing something bad. And so I like to reverse that and think about how can we enable health, and how can we enable the people that we interact with to not die from an overdose, and to not get hepatitis C, and to not end up in the emergency room. And so all the important work you guys are doing is enabling people to stay healthy. And so we can all proudly call ourselves enablers. And I'd love to take questions.
Great, thank you. We're going to open up for questions. Before we do, just so Dr. Wakeman has an idea. So in this collaboration, we have the hospital, South Shore Hospital, Brockton Hospital, Bethesda, Deaconess, and we'll meet with Partners Healthcare in the next week or so because of some of the partnerships here. We also have recovery coaches, there's licensed clinicians, social workers, there's police officers who go in plain clothes with the recovery coach, social worker, or licensed clinicians on these outreach visits. As I was looking at your presentation, and Chief was talking a little bit loud, but as we were talking, we were talking about that collaboration, all the different multifaceted approach. We feel like Plymouth County has all those pieces that adding in some of these expertise I think would be very helpful. But with that, does anyone have any questions for Dr. Wakeman?
To access your Bridge Clinic, do you have to have an MGH affiliation, whether you're inpatient or in the ED, or can you accept people from?
So technically you're supposed to have an MGH record number, which is pretty vague, meaning at some point you've been in the emergency room or somehow affiliated. The hospital funds us, so the goal of the clinic is to try to care for patients in the system. That being said, we don't turn people away, so our goal is to help people when they walk through the door, and yeah.
Chief Patera?
So I want to talk a little about how, as you know, our Plymouth County Outreach Program initiative is this follow-up piece.
Yeah.
And interesting, I think a lot of things you talk about are things we've considered. And the stigma is a big piece, but it's still strong, we know that. And obviously the model you talked about where you have the mobile treatment, that's interesting. That's a lot like our drop-in centers, obviously not mobile, but looking to combat that stigma piece. So our program has grown to a factor we think law enforcement has this front row seat. So we'll be able to connect someone we know overdose and has an issue, and we want to try to connect them to treatment. If they don't take treatment at the hospital, we conduct this home visit follow-up and offer resources to clinicians, as the chief said. So that piece, we then found, we started receiving phone calls to mostly police departments saying, my son or daughter is going to overdose eventually. These subjects at risk are activating into our network saying, can you help me? So it's an interesting piece. We really didn't anticipate that. So what we need to do, what I want to ask you is, what do you think is our next move, and how can we partner with the medical community to offer a medically assisted treatment to these subjects that are calling in or people that we're conducting follow-ups with?
Yeah, so I think partnership is great because I think the idea is that you have this moment where you have an opportunity to engage and connect with someone, and the last thing you want to say is come back tomorrow or come back in a week or let me make some phone calls and I'll get back to you. You want sort of an immediate entry into treatment, and so I think partnering with local health systems to try to think about that immediate access model. So what would it take to be able to, when you get one of those phone calls, to say, oh, someone can see you today? You know, that really should be our standard of care, and it's hard to get there, but it's possible. And so I think those conversations are really fruitful, and more systems are moving towards this idea of kind of a bridge clinic model or urgent care model for opioid use disorder, where, you know, people don't really need the emergency room. What they need is immediate access to treatment that same day. And so that can be in a primary care office, that can be at a place like Clean Slate, that could be, you know, in a behavioral health setting, but just figuring out who those partners are.
Thank you. And that's another piece we're looking at, is the critical 24-hour, 48-hour period where you want to offer the resource and then have it available so they can, you know, get right into the program. Thank you.
Just before the next one, on the advisory board, so we have Dr. Jason Tracy from South Shore Hospital, who's here today. We have Dr. Dan Hughes from Brockman Sigma Healthcare. I don't know if Dr. Hughes is here today. And then we also have the Plymouth Board of Health Director, and then BID Plymouth has been from the get-go. So, you know, I guess to follow up on Mike's question, how do we, you know, as a group talk about, you know, because right now, if you said to me, I've got someone, where can I bring them for medically assisted treatment? I mean, we have Crossroads, Clean Slate, but other than that, where else, you know, how do we, you know, make that network connection down here?
Well, I think that's a great conversation for your champions groups. I mean, part of our, we also have these champions meetings, and part of the conversation in the champions meetings are what are the existing, or what gaps still exist, what have we not been able to do, and where do we feel the need is, and how can we think creatively about meeting that? And so, you know, immediate access to treatment is one of those gaps, and so what would it take to creatively think together about being able to offer that?
So Chief Walsh from Wing.
You know, something that I've learned and my officers have learned, and I'm sure many other officers have learned, is that recovery is, because we're new to this part of the equation.
Of course.
The recovery is a process, and it has to be a patient process versus having inpatients.
Yeah.
And not being patient. What is, you know, where in the process can education to the user also be concentrated, where that person has to understand a 30-day stay in a detox isn't going to cure you. You have to have patience in this process. Does that seems like it should start very early in the process. There are users that come out and say, Chief, I went to a detox for 30 days. It did nothing for me.
Yeah.
It doesn't help me.
Yeah.
So it seems like that education, that this is going to be a long process. It's going to take a while. It's going to take 2 years. It's going to take years. Is that part of?
Yeah, I think that's huge. I think educating people who are affected by the illness and families who are often still looking for detox or paying cash for these, you know, highly expensive and often not super effective programs. So I think really educating people around what does good treatment look like? What should you be looking for your loved one? If you're a person with this illness, what should you expect from treatment the same way we do with any other illness? And I think providing that education can be a relief to some people, because I've had people who they feel like they've failed because they've gone to detox detox 100 times and they haven't been able to achieve recovery, and so they're never going to get well, or they've done something wrong. And so, providing that education that you haven't failed, but this is not the right treatment approach, and it's really the system that's failing you, and this is what effective treatment looks like, can be really useful. But it has to happen again and again, and we're undoing, what people read in magazines and, celebrity rehab and all of these TV shows that send kind of false messages about what it looks like to get well. And also I think that, there's a huge industry, a private rehab industry that's profiting off of this kind of magical fairy tale that you can go to Malibu for a month and come back and be better. And so, I think combating that, really providing science-based education around what effective treatment is incredibly important.
And I think if the education was stronger in the first stages of the recovery process, that might help the long-term results.
And good treatment should provide that education as a part of their treatment.
I'm going to go right here, and I saw Chief Stewart had hand up. We're going to get all your questions, so we'll get right around the room.
Well, it's not so much as a question as a comment. Like, we're CSP workers at High Point in Plymouth, and a lot of times people want to continue with treatment, but there's a lack of beds. So then they're kicked to the street, then they use again just to get back into treatment. It's just like this vicious circle. So it's just like, we could build a lot more facilities. Wouldn't that be fantastic?
Yeah, and all levels of care, and not just treatment, but supportive housing. I often think a lot of my patients that are going to residential treatment, with good supportive housing and outpatient treatment, they probably would do as well, but there's such a lack of supportive housing, and people, if you're homeless and trying to get recovery and stay engaged in care is incredibly hard. So thinking about all the different gaps that we need to fill in the system.
When is the whole clinic that you had mentioned, when is that supposed to be opening?
April 18th is our go live date.
And are they still, like you had answered that they need a file number already? Does that?
So I think it's through the same philosophy applies, that it's, its primary mission is to serve patients who are already in the MGH system, but we also don't turn people away.
Thank you.
Dr. Tracy right here from South Shore.
Absolutely fabulous presentation. Thank you. Somewhat depressing to be a physician to watch this and hear this, because I do think that we have a long way to go. But in a lot of the collaboration that has occurred with people in this room, I think particularly in our area, we're primed to really tackle this issue here. We did have a recent discussion on a delicate subject, but I think my colleagues on the law enforcement side and on the ED side, we struggle with the really at-risk individual, the multiple overdoser we've seen 2, 3, 4 days in a row in a car accident. You have family that is either really begging police officers to do something, or emergency department providers to do something, or any of our clinicians in here. But there's a lot of debate around the use of coercive treatment in Section 35s. What's your thoughts on how we tackle that? Because again, every time I have this conversation with all different disciplines, everybody wants to do the right thing, but it seems to turn into somewhat of a charged conversation and topic. And so I think we're looking for a little bit of guidance as to what you think.
So I think there's no simple answer. I think my first answer is that I think as we've kind of heard, we have a long way to go in making voluntary treatment immediately available and really welcoming, that even treatment that's available sometimes isn't opening its arms to the highest risk person and really welcome them into treatment on their own terms. And so I would love to see that expand, where we really have immediate access to treatment 24/7 available for people. And I think if we built that system, there would be fewer and fewer cases where we truly have someone that is completely unwilling to engage and is at imminent risk for death. With all health conditions, there are people that are unable to care for themselves in the community who we, keep safe through coercive measures. So, we do that for patients with cancer who are unable to care for themselves, but it's a tiny, tiny minority. And so I worry that we sometimes use involuntary treatment as a fix for the system being broken. And, part of that is shown by how many people section themselves. A huge number of sections are done by a person, so they're not involuntary involuntary. They're a person asking for treatment and not knowing where to turn. So I would love to see us build up our system so that we maximize all voluntary options, really rethink, why is it that people don't want to engage in care? What is it about our systems that are not welcoming and engaging and helping meet people where they are? And then reserving involuntary treatment for really the highest risk folks that even with all of that are not able to connect.
Just to follow up on that, so in Plymouth County, there were 1,769 overdose events last year. We have that because of this information sharing system we have in Plymouth County. There was 1,350 unique individuals, 242 accounted for 36% of all the overdoses. So that high-risk population is where we really struggle. We've been told, you're forcing people, of course, the officers that go to these outreach visits, we've never been turned away the door, and it's always, hear the options and then walk away. So I guess, one of the struggles we have is, there's the perception that we're forcing people in treatment where realistically on 10 visits, maybe one of them will do it, but I've seen it, it's the 6th overdose in 2 days, the 3rd overdose in a day, and we get it. We would prefer to do another option, but what do you tell a parent when they said, you need to do something, and what else do I do? And I guess that's where we struggle.
Yeah, totally. No, and I think your point that these are all of the reactions to these circumstances are well intended, and that everyone wants to save someone's life and to respond to kind of the desperation of the moment. And so thinking about how to really have lots of options. So to the question earlier, that you have somewhere that in that moment you can take that person that doesn't necessarily have to be a courthouse, I think is crucial. The other piece that's often missing is I think it's phenomenally important to have the voice of people in recovery at the table, but also the voice of people who are actively using that. When we think about designing systems to help a population, we need to know what they think they need. And so that voice is often not a part of our panels and our discussions. And so really thinking about sort of the active drug using community and what they think would help them stay safe and engage in health services.
Unfortunately, on the same topic, the challenge we have in law enforcement is we have this tool.
Yeah.
We don't use it. The person overdoses and dies the next day.
Yeah.
We have a problem there.
Yeah.
So it's a struggle.
Totally.
To do it. And I know there's no clear-cut answer to it, but
Yeah.
I think even in the medical field, I think people need to recognize that there is a time when someone overdosed 3 times in 2 days, and there's no one that's going to be coming forward to go for good reason. It's a stigma. Family members just can't go to court and get the nerve to do it. They gave us that tool for a reason, and in 30 years of policing, the officers here, we never used that ever. We never did. We would let the medical people do it. But now we're finding that it's a tool that we, as a last resort, it's just hard to walk away from that subject thinking that tonight they could overdose and die. So, and I know you see our struggle, but that's a really difficult spot for us because we have the tool, and then it's hard to decide not to use it, So it's a difficult piece. So I understand we want to really do a better job of having people self.
Yeah. And then the other piece of that is when people are coerced into treatment, are we certain that they're going to places where they're getting the best standard of care and where they have access to medication treatment and things like that? That's another piece.
We actually have gotten that criticism that, they're not going into a great system.
Yeah.
But there's only so much we can do.
Yeah, of course. No, you guys can't fix that.
We're
Yeah.
in the systems that exist. So
Yeah,
definitely
totally.
Focus on better systems, but it's really all we have.
Yeah.
And I think we know it's not a perfect fix. The chief was talking about it's a long-term fix. But it saves them for the moment.
Yeah.
It lets the family take a breath and maybe then get some more resources. So
Yeah, no, I hear that. Yeah, absolutely.
Do we have any other questions? Brian Kuhn?
Oh, sure. Yeah. Yeah, so it's called Care Zone, and this is the mobile treatment unit for people who didn't hear the question. It's actually funded in part by Bob Kraft and through the Kraft Center at MGH, as well as funds from the GE Foundation and some other foundation support. And it's essentially like a retrofitted Ford van. So it's like a medical office on wheels. So it has an exam room, it has like a reception area, and so it's literally mobile treatment. It's got Wi-Fi so they can connect to the medical record, and it's staffed by addiction medicine doctors from Boston Healthcare for the Homeless program, who we partner closely with, who are already sort of engaging with people on the street. And then our Public Health Commission's outreach workers. They do a lot of the sort of concrete harm reduction work on the streets, like syringe exchange and things, and Narcan distribution, things like that. And so the van currently is going to hotspots, so areas in Boston that have the highest rates of overdose. So the Dudley Square area and the area around kind of Haymarket, North Station, in Boston, and the goal is to connect with people that are totally disconnected from the health system. So to try to literally bring treatment and engagement to people on the streets. And so they offer addiction treatment, they offer kind of basic primary care, vaccinations, harm reduction services, and trying to connect with people and sort of bring them into care and then ultimately transition them into ongoing kind of community-based engagement and care. It's 5 days a week currently. Yep. Yep. And the hope is to expand if it's in pilot phase right now, but if things go well. Yeah.
There's 2 regional drop-in centers, East Bridgewater, actually 3, Wareham, and then in Plymouth. I mean,
Right.
we were just talking, actually, if we could somehow push that out in this area in a
Yeah.
mobile, because we have all the treatment partners, recovery
Yeah.
partners at the drop-in, but putting it in
Yeah.
something similar to that might be, a direction
Yeah.
that we try to, think about going.
You're actually walking up to people on the street.
Yeah.
Obviously, you see
Yeah,
them,
yeah.
you go up, you ask them, for
Yeah.
resources.
Yeah, exactly. Yeah. Yeah.
Does anyone else have any other questions? I know we will afterwards, but because it's really opened a lot of engagement. We appreciate it. We're going to take a 5-minute break, then come back with Brian Coonan and Sarah Cloud. But thank you very much to Dr.
Great.
Wakeman. Thank you.
Thank you. Thanks. Thank you so much. No, great questions.